All right. Good afternoon and welcome to today's webinar, Disparities in Childhood Health. This important topic will be discussed by Dr. Andrea Singh, who is the chair of pediatrics at Park Nicollet Clinics and also the co-chair of the Health Partners Children's Health Initiative, and Dr. Jason Maxwell, pediatric chair at Health Partners. This webinar will be recorded and available for viewing on the Stratus Health website on the Healthy Start project page, and I will add that link in the chat later so that you have it. There will also be an evaluation for you to complete at the end of today's presentation. It will display on the very last page of the webinar, but I will also put that link into the chat so that you can complete the evaluation for us. And then by completing the evaluation, that's how you'll receive your certificate of participation. We also welcome your questions as we go to, you can submit your questions via chat and we'll monitor the chat, and our presenters, we'll possibly talk about them as they see them, but probably save them till the end of the presentation. So today's webinar is brought to you by a collaboration of the Minnesota Medicaid health plans. We all work together to ensure a healthy start for Minnesota children. We are concentrated on improving services provided to pregnant people and infants, and particularly are focused on reducing racial and ethnic disparities. So the health plans, you can see who are collaborating on this project. So thank you to everybody. And now I'd like to turn it over to Dr. Maxwell.
Thank you, Patty. Good afternoon. We are honored to have this opportunity to speak with all of you today about disparities in childhood health. Andrea and I are actually passionate about this topic. We have done this for years, and we are overjoyed that it is now taking the attention of the rest of American healthcare. In general, no single person or single entity is going to be able to solve this issue. It's really going to take a team effort. In my opinion, together we are all stronger, we are smarter, and we are better. Andrea and I, we kind of broke our talk into 5 themes, I guess. The first will be a primer about equity versus equality. The second is a discussion about Minnesota's changing demographics. The third is a presentation of disparity examples that we see in our own care delivery system. The fourth is a discussion of potential causes of those disparities. And the last one is a discussion about some techniques that we are employing trying to close those care gaps. So we'll begin. In general, we are only going to succeed if we can develop a team that understands and also agrees with a mission. And unfortunately, I found that sometimes our care team members don't understand the mission. And if they don't understand the mission, they're not going to be as engaged as they need to be. A critical piece of this is educating our staff about diversity, inclusion, disparities, and equity. But we need to do this in a way that educates and informs our care teams. And we have to do this in a way so that they can be engaged in part of the solution. And we have to do it in a way that we don't turn them off. Not long ago, I actually attended a lecture. And the lecture started off with this quote: "We are all part of a racist society." All right. Well, although maybe it's true, I don't know that I find it to be very helpful to start something like this. It simply puts a sizable percentage of the audience on defensive, or it makes them feel very badly about themselves. And in general, neither of these feelings is going to build a team that is engaged or passionate about our mission. Instead, what we need to do is we need to meet people where they are in their journey, and we have to help educate them in a very thoughtful and compassionate way. So to begin, I'd like to start by focusing on equity. Over the years that I've done this, I actually have found that many people, maybe even most people, do not really understand the difference between equity and equality. And in fact, I don't think I understood this until maybe 4 or 5 years ago myself. So overall, I think the first part of this work is we have to teach all of the stakeholders the difference between equity and equality. And this slide here, which comes from the 2019 Design and Tech Report, this is my favorite slide that can elucidate the difference. So equality, we're going to start with the equality. Equality means that every individual or group of people is given the same resource or the same opportunity. Equity is actually different. Equity recognizes that every single person comes from a different background. We all have different circumstances, and equity will allocate the same resources and opportunities so that we can get to the same outcome. So in other words, equality focuses on giving people the same resources. However, equity focuses on giving people the same chance of an equal outcome. So one of them is focusing on resources, the other is focusing on outcome. And this slide really explains this well. So many systems are unequal, and some systems are naturally unequal, but some systems, they become unequal over time. In this example on the top left, you'll see that this tree is tilting towards the left. And in addition, the left side of the tree has far more apples than does the right. In this system, the person on the left has a better chance of outcome based solely on this system. It has nothing to do with them themselves. In addition, the person on the right is going to face many challenges, and this is through no fault of their own. They just happen to be born on the right side of the tree. A solution based on equality would be to give each person a ladder of the same size. So if you look at the top right panel, you'll see both people have the same exact ladder. They've been given a solution based on equality. But here's the problem. This solution allows the person on the left to get even more apples than they had otherwise, but it doesn't help the person on the right at all. So in this case, a solution based on equality isn't going to be helpful. A solution based on equity, on the other hand, might be to give each person a ladder of different sizes that allows both persons to reach the apple. So the bottom left panel, you'll see the solution based on equity allows both people to get an apple. Even more so, a solution based on justice would be to try to tilt the tree to the center and in addition get the apples to grow on both sides. There are two very important pieces to this slide that I think are extremely important to call out. The first one, the person on the left has a better outcome solely because of this system. And in addition, the person on the right has a worse chance of a poor outcome through no fault of their own. So in other words, this is a problem with the system. This is not a problem with these individuals. The second thing that needs to be called out is that this system may or may not be natural. A lot of systems seem natural because they've always been this way. However, some systems were actually created in an unequal way, and others become so over time. In this case of the tree, it is possible that the tree just grew this way, that it's a naturally unequal system. However, it is also possible that a bonsai tree artist came in 200 years ago and bent the tree to the left. What this leads to is a very important implication. In this case, neither person under the tree is responsible for the creation of this system, and so neither of them is to blame. In addition, though, they both do have a responsibility to fix this if this is indeed an inequitable situation. I think if we can think about inequality, injustice, inequity, and in this way, it will help our team members to understand that they might actually be part of an unjust system, even if they are not unjust themselves. It also helps them to understand that they need to be part of the solution, even if they have no individual blame. In other words, this way we can take out the emotion, and now our team can help understand the problem, they can believe in our mission, and this will help them help us to resolve the problem. Once we've taught everybody about unjust or unequal systems, then we can address the root causes of the disparity and improve it. Next slide. Sorry, next slide. Here we go. Minnesota. So, Minnesota is consistently rated as one of the healthiest states in the country. I think the last time I saw the ranking, we're number 3 out of 50. It's always like us, Massachusetts, etc. So we are a very healthy state. Unfortunately, not all Minnesota children share in this excellent health. When we look, we see that there are differences in outcome based on race, income, language, age, sex and gender, sexuality, geography, religion, and increasingly in 2021, actually politics. Political affiliation is a big determiner of health these days. Of note, there can be overlap amongst these groups. So as an example, our Black, indigenous, and people of color children oftentimes tend to live in lower income homes if you compare them to our white counterparts. Next slide. Minnesota, ever since I've been here, has long been considered a very homogeneous state. In my opinion, though, I think there's actually been more diversity here than was previously recognized, and Minnesota is changing at a very rapid pace. In this slide, you can see that of the Minnesotan children who live in our state, about 56% of those kids live in the metro region, and about 44% of those kids live in the greater Minnesota area. In addition, 13% of our kids have lived in poverty as of 2017. Next slide, please. In addition, over 500,000 kids are on Medicaid, and this makes up over 40% of all Minnesotan children. And there was a stat a few years back that showed that for the first time ever, more kids in Minnesota were born on Medicaid compared to born on commercial insurance. Next slide. In addition, our racial demographics are changing very rapidly. This slide here is from our care group, and it shows the demographics of the patients that are part of our care group as of 2021. Our care group is concentrated for the most part in the 7-county Twin Cities metropolitan area, but in addition to that, we also do serve central Minnesota and also western Wisconsin. So in other words, we serve patients in urban, suburban, and rural areas. And although we might not today have the data for Minnesota itself, overall demographic data from our state it does somewhat emulate this data here. Overall, in our care group, about 70% of our patients are white. However, if you look more closely and if you break this by age band, you will see that for our patients who are 65 and older, 87.6% of them are white. However, if you compare that to our kids who are under 14 years of age, only 54.2% of those kids are white. In other words, only about half of our pediatric population is white. Next slide. Not only that, these changes are going to continue and they're going to accelerate. This data comes from the state of Minnesota, who estimates that our white population will grow approximately 8% from 2015 through 2035. However, our African American population is going to grow 113%, and our patients of Hispanic origin are going to go up 248%. So given that, we're going to find that our patients are going to become increasingly racially diverse over the next 15 years. So if I was to summarize the last few slides that I've just gone over, number one, we know that there are health disparities based on geography. Well, half of our state lives in the metro region, half doesn't. We know that there are disparities in health outcomes based on income. 13% of our kids are under the poverty line, and 40% are on Medicaid, which does indicate it's kind of a proxy, I guess, for kids who are kind of on that edge, who are in lower income households, who may face food and housing insecurity. We know that there are disparities based on race. Soon, half of the children born in our state are going to be Black, Indigenous, or people of color. So in other words, if you start adding up all of these groups, the people who live in the more rural areas, the people who live underneath the poverty line, the people who are on Medicaid, the people who are of color, a sizable proportion of Minnesota children face health equity disadvantages. And I haven't even showed any data that's based on sex, gender, religion, or political affiliation. So in other words, we have to tackle these disparities because they actually affect a plurality of our patients. This is not a minority problem. This is a plurality of Minnesota kids. So that's the why. Let's turn it over to Andrea.
Hey, everyone. I just want to say thank you for having us. Jason already reiterated that, but we know that, I'm going to make an assumption here that many of you on the call, we are preaching to the choir. You understand that these are super significant issues that face the plurality of pediatric patients in our communities. And it's not just a Minnesota problem, although it is definitely a problem that we face as folks that are invested in healthcare here in our state. So as Jason said, he kind of gave you some of the background of setting the stage for these conversations and how we can bring some of these issues to our team. My little section here will be really talking about the what. So we've talked about, who makes up the demographics in our state and how we can kind of break that down. We'll go through a few slides here, I think 4 or 5 different slides that go through what are we seeing specific to the Health Partners Care Group, but I think that they can be extrapolated. And I know lots of most care systems in our state are looking at this data. And I think it'll line up with what other folks are looking at. First of all, we wanted to kind of set the context. We are not project managers, but we know that whenever we tackle a problem in healthcare, we have to be systemic about how we are addressing it and acknowledging that it's an issue, and then set up some clear plans and define how we're going to then tackle that and determine root causes. So, this is something probably most of you are familiar with, but the first thing we have to do really is determine if a disparity exists. And that's the first section I'm going to go through. Then we're going to tackle determining potential causes. I'll be honest, I wish that Jason and I could come here and tell you that we've solved this problem, or that we've really defined all of the causes and now we're going to tackle, next steps. Obviously, that we are working on figuring out potential causes. We are not going to be able to solve all of the problems, but each piece of the puzzle that we make easier and reduce some of that systemic disparity, the better the outcomes will be. So it's one step at a time with this work. And I think that's important to put into context. We've got some potential solutions for each care group, and we'll give you some examples of what we've done to work toward this. Recommending the possible solutions in healthcare is really different than implementing the recommendations. And unfortunately, we don't live in a vacuum or with the unlimited budgets of some of the bazillionaires in our world, where we can just say, well, this is a really great idea and we have unlimited resource to do what we want. But I think it's really important that as we have these conversations within our bubbles, that we bring back to those that determine resource allocation and help set priorities for our systems, organizations, schools, wherever you're at, that the long-term benefits of dedicating more resource to this area far outweigh any of the short-term costs. Sometimes that's a hard sell, and let's be honest, we have to balance all of the needs, and sustainability is a huge need, and systems need to keep operating. But at the same time, the long-term benefits have been proven time and time again to provide both, societal, health, financial rewards if we do this right. And then we study the outcome of the solution, because we can't implement a solution without then looking at measurement data and saying, is this working? How do we sustain this? And now can we enhance these projects? We try to do this whenever we look at things in the pediatric realm here at Health Partners in Park and Gillette, and I know many of your systems do the same. I also just want to give a huge shout out to all the stakeholders who are involved, because this is not a one group problem. This is not a pediatrics problem. This is not an insurer problem. This is not a problem only for public health or our school partners. This is a problem that we all have to be invested in and all take a place at the table to discuss, because kids' lives are multifaceted. We talk about all the time that, only 20% of overall health occurs in the healthcare office setting itself. The other 80% is all of those other parts of your life that happen that absolutely affect physical, mental, social health outcomes. So, and this is where all the social determinants of health work that we're all doing comes in. So we wanted to give a big shout out to all of you. Simply by being here on this call, you are acting as a stakeholder and hopefully working toward all of the pieces of this plan, do, study, act cycle, the PDSA cycle. All right, next slide. So we're going to get into a little bit of data. And as I said, this is data from our care group. So, just one snippet of what one large organization that serves, a large number of children, almost potentially the majority of children in the metro area, is seeing in our group. And we tend to break our data down by both race and payer. We have other breakdowns that we also get. We recently added, say, language as a variable, but for simplicity's sake and for, being illustrative for this group, we decided to show the breakdown of some of our data by race and payer for you guys. And certainly there are more granular breakdowns as we go forward. So this particular slide that we're showing you is our pediatric 10 immunization combos. Across the state and across the country, we have really struggled with the disparity gap when it comes to getting all of our patients immunized. And obviously there's lots of variables in there, but you can see what we're seeing with our race and payer gaps in front of you. I'm not going to repeat the numbers. We looked at this data kind of in December 2020, all the way to May 2021. The good news in some of this is that we've improved over the past 5 years, and that's been very deliberate. And we'll talk later in the webinar about, some of the measures that we've taken and steps that we've gotten to get there. The bad news is that we still got a huge gap. And I think it's always interesting to look at data. Like when you look at the race data on your left, you can see that actually we've declined a little bit in getting our immunizations for white patients. We've improved for patients of color. So that closes the gap a little bit, but it's not exactly what we want if we're declining in one group to close the gap. So we always have to be conscious of thinking about data and really looking at it. I would also say a couple of things. One is our Health Partners Institute, which is our great research arm here at Health Partners and Park Nicollet, did a great analysis during the pandemic of immunization rates across the country. And what they found was that even in locations where we didn't have big disparity gaps in immunizations pre-pandemic, as we moved through the pandemic, those disparities started to show up. And a big piece of that is just getting access and getting these patients into our clinics. We can't do what we need to do if we can't get to the patients themselves. And you'll see that with some of the other data that we have. Immunizations is interesting, and obviously our combo 10s are measured based on children that have had a well child visit in the last year. So these are patients that are already somewhat invested in our system and our healthcare, and we've still got a big gap. But it becomes more challenging to deal with when the immunization timing may not line up with when they're actually physically present in our clinics. And so as a care delivery system, we struggle a little bit with this compared to some of the other data I'm going to show you. Next slide, please. So, and this kind of shows what I was talking about there with, we still struggle with disparities in some of our other measurements, but not as much as with IMS. So this particular slide is looking at disparities in developmental health screening and specifically our ASQ3 screenings. And you can see that the gap is much smaller than when you look at the IMS data, but there still is a disparities gap, both when you look at race and when you look at payer. Now, obviously there's some overlap. Some of the same kids are going to be race and payer, on the right side of the bar graphs there. But you can see a couple of things. One is that on the race data, as well as the payer data, we went down as we went through the pandemic in terms of getting these screenings done for kids. And there's a lot of, reasons why that potentially could have happened, but we're actually doing a decent job in getting, 88% and 84%, 87 and 83% of those kids completely screened. So we're doing a good job, and there's a lot of work to do. One of the things with our developmental screening, and we'll talk about this later on, is one of the solutions that we've implemented for some of this disparity stuff, that we have universal processes. So if we get the child in the door, we are hopefully doing these screenings and have set up processes where we can get them done. Next slide, please. The next one that we have, again, a developmental / emotional / social health screening, our MCHAT form. Those of you that are familiar with both ASQ, our Ages and Stages questionnaire, and our MCHAT, which is our autism screening questionnaire, know that both of those forms have a lot of words on them, right? So some of the pieces to this puzzle that as we're thinking about why do we have disparity gaps, we think about our literacy levels, right? You can't fill out a form properly if you can't read it and understand it. Language barriers, in addition to simply processes. Here we can see a little bit of a bigger gap when it comes by both race and payer than we had with our ASQs. MCHAT is a very wordy form and sometimes challenging for patients to fill out. What we will also see here, which I think is interesting to point out though, is if you look from December 2020 on the race data and the patients of color, we actually did better by the time we got to May 2021. So, again, different than what we saw with the ASQ. Why? We're still figuring that all out, and there's still significant gap. Next slide, please. And then we want to just take a different view of it. And this is our adolescent mental health screening. So it's not just toddlers and younger kids that were shown in the first 3 slides, but also our teenagers and what we're trying to do, and that identifying these gaps again here. Here, you can see that the data between race and pair are very similar. And then there's not as big of a gap, but there's still a gap where there shouldn't be. So areas of opportunity, I would say. Next slide, please. All right, so we've identified that a gap exists. I think that it's hard sometimes because if you work in healthcare, you work in the school system, you work in public health, you feel like our teams are well-meaning, that we're doing this work because we want to help all people in an equitable manner. And so sometimes we don't think that we are the problem, it's other people that are the problem or other systems. And so that first piece of identifying, yeah, no, it's us too. And okay, now that it's us too, what potential causes, could there be? So I think obviously the 6 boxes in front of you are not a comprehensive list of every cause of disparity in healthcare, but these are some that Jason and I have really identified and helped our care system identify as major issues. And we will address these as we go through the rest of the talk. You'll see in some of the future slides a little box at the top that kind of calls out which areas we're hitting as we're trying to address recommendations and solutions. So the first one is ignorance that the disparity exists. And I think that is very much in alignment with what Jason spoke about at the beginning of our conversation, and setting the stage for your teams about the difference between equality and equity, why it matters, and how we can still be good, well-meaning people and be in a system that has inequity. Access, big deal. We talked about that with the IMS, and we have to get our patients across the board in our door potentially before we can help them, especially when it comes to something like immunizations, where it's a medical procedure, that medical intervention that we have to take. We've got operational hurdles. We talked about that with kind of some of the budget and resource conversation. There are trust issues. This is a very hot button topic, and people have strong emotions when it comes to disparities, systemic racism, equality versus equity, et cetera. And so trust has to be built. And I would say that that's trust with your care teams in the interventions that you're pursuing and the reason that this is important, but also very importantly, trust with our patients. And lack of trust can be a reason that patients don't come in the door. Historical trauma is real, and there are very valid reasons why patients may be fearful of entering a traditional healthcare setting, or a school setting, or a system of public health where there's government associated. And we have to acknowledge that and help build trust. Trust is earned. And so we have to put our, actions into place to help people understand that we are looking for the same outcomes and not just giving this, talk. Education and access to information, I think, is important, and that feeds into everything else we've talked about. And then obviously bias, beliefs, and cultural differences. Again, patients and staff. We're talking about everybody when we're working toward this. So I think now I'm going to hand back over to Jason, and he's going to talk about methods for reducing the disparities in our system.
Awesome. Thanks, Andrea. So, only after we identify and understand these disparities and also their root causes, only then can we create a solution. And as we begin this kind of last part of our presentation, I'm going to echo what Andrea said, that it's important to understand that we've made huge strides over the years, and we are nowhere near to solving this problem. I know and I'm sure Andrea, we're very proud of what we've done, but there's just a lot more work to do. Next slide, please. The most important solution, as I said at the very beginning of this presentation, is to get the entire team to believe in the mission. We are not going to solve this if every role is not engaged. So for our organization, this means all of our support staff, our LPNs and CMAs, our RNs, our doctors, our nurse practitioners, our overall leaders and administrators, all the way up to the CEO. Everybody has to believe in the mission. For everybody listening to this presentation today, it's true at your organization as well. If you're a large healthcare delivery system like we are, or if you're a smaller community clinic, a public health department, an insurer, a school, or any old employer. The first thing all of our institutions need to do is make diversity, inclusion, and equity a priority for the entire organization, and then create a mission that the employees understand, and then set up an environment where this mission can thrive. In order to do this, every leader must be on board. This will signal the importance of the culture to the rest of the staff. This is done more easily, actually, if you can hire a diverse workforce, because especially if that workforce reflects the community. And then also if you can ensure that everybody feels welcome and included. The primary way, again, to do this is to educate our staff. We have to educate our staff about diversity, inclusion, and health disparities, about racism and anti-racism, and even about cultural humility. The education has to happen in a thoughtful and compassionate way, and it needs to be done in a way that doesn't put our staff on the wrong side of the equation. So as an example, using the slide that I did at the beginning of the presentation. Building a team full of individuals who believe in the mission will then lead to a self-reinforcing positive loop, which makes all of the other work easier in the future. We have to create a culture where everybody feels welcome. This, again, is going to require buy-in from all leaders and all staff, and it requires anti-racism training because a lot of this is not obvious to people, especially if it hasn't been part of your day-to-day. For instance, our CEO, Andrea Walsh, she has made diversity, inclusion, and equity a priority. All of our staff in our organization have received education about the importance of these topics. In addition, we have a well-staffed and I think well-funded Department of Diversity and Inclusion. And we also have a health equity, inclusion, and anti-racism cabinet, which our CEO is part of. We have multiple groups that are set up specifically to deal with closing identified care gaps, and every initiative that comes through our enterprise must be evaluated using a lens of diversity, inclusion, and equity before it can be rolled out. By doing this, we are trying to make sure that all of our staff know that diversity, inclusion, equity, and disparities is a priority for our enterprise. Next slide for Andrea.
All right. So in addition to what Jason said about, working with our teams, and I think we cannot underestimate or underemphasize the importance of people in this conversation, which is why we spoke about that first. But we know that it's not just about educating and talking and trying to get people on the same page. We actually have to back up what we talk and educate about with actual action. So this slide, we're really talking about some of the efforts that we have made to improve access and remove barriers. And here I would say that one of the things that we don't, necessarily call out here, but is inherent to any of this being successful is the trust piece that we mentioned earlier, because you can add evening and accessible hours for those patients that may have transportation barriers or not be able to leave work to have a doctor's appointment for their child. You can improve interpreter access. You can do all of these other things on this slide. And if folks don't trust that you are working toward a good outcome for them and that you're all on the same page, it's not helpful, right? But these are the things that we can do as a care system as we are trying to earn trust. So yes, extended hours is a big deal. And it's different for a lot of healthcare systems and people serving children to think about working outside of traditional business hours. In the Park Nicollet part of our care group, we have for over a decade, had extended hours and really trying to serve the families that we need. And now we've got it across our care system, which I think is a really important piece of recognizing that everybody does not fall into those traditional, 9 to 5 hours. And we have to be there for our patients in the same way that their healthcare isn't defined by a clock on the wall and things like that. Improving interpreter access has been a really important piece of this. Interpreter access, to be quite blunt, is expensive. And so we have to figure out how to get the interpreter access, which is absolutely needed, to the right patients in the right way so that it's most effective. So we're using this resource appropriately. And we recognize that more and more of our population don't speak English as their primary language, and we can't really optimize their healthcare if there's a language barrier and they don't know what our recommendations are because we're just scooting by. That's not equitable care. And so we have to acknowledge that and work toward better. And I would say many of the things that we have on this page are not just true in healthcare. They're true in any service that is available for patients. So, thinking about visits via video visit, there are other services, whether it's like OTPT or something else that can be done through video, school services, etc. We learned a lot during the pandemic, and we learned that there are other ways to get to folks where access may be an issue. And we are going to continue to optimize and enhance what we've learned over the last 15 months. Park Neglect and Health Partners, like many other care groups, implemented some drive-through services during the pandemic to provide vaccinations, to provide testing services. I think these can be utilized in the future as well, depending on where the need is and looking at ways to think outside of the traditional care delivery box. Adding services to urgent care. So we partnered with our urgent care, knowing that because access is such a barrier and we have such a disparity gap with IMS, that sometimes some of our patients are not entering the primary care world. They're going to urgent care for acute needs. Preventative care is not the top of the list of what they're worried about for their families. They may be worried about getting food, then keeping their job, having housing, and coming in for a well child visit for a child that otherwise seems fine may just not be there. And so they end up going to urgent care for acute needs. Well, we partnered with our urgent care teams to say, can we try and get these patients vaccinated for their routine vaccinations during an urgent care visit? And again, there are some operational barriers and things to work through, but it's a really cool partnership that I think can be extended to other systems. Walk and well care, not turning people away if they show up at your doors and are in need of preventative health care. How can we, make that work in our teams and our system? And then just doing really robust outreach to remind folks about why preventative healthcare is really important for kids, what your services are that you have to offer, ways we can meet these needs that may be in non-traditional and they didn't even realize that we, for instance, had video visits as an option, and utilizing different ways to meet patients where they're at, right? So traditional mail may or may not get opened in many households. Traditional mail may be in English and they don't speak English. There are, patients that won't open their traditional mail if it comes from their healthcare organization because they're concerned it's a bill and they don't want to open it up. They don't realize it may be a reminder or some advice. And so using other modalities that are more accepted by our patients, like text, social media, online accounts, are an important part of how we can improve access and remove barriers for patients to have health information. And I think social media can't be underestimated there because, a lot of people will get health guidance from the internet. And if we as healthcare organizations and public health entities are not out there in that mix, they're going to be getting it from other sources. So us kind of making sure that we are leading the way and presenting that information to our patients is really important. So those are just some of the things that we've done to improve access and remove barriers. I'm going to pass it back to Jason, and he's going to talk about some other things that we've done.
Thanks, Andrea. So, as we looked at our system, we found that we could make some operational improvements. This comes back to just being open and honest and understanding that the system that we had built was not necessarily equitable, and maybe through no fault of our own, but it didn't mean that we couldn't change. So for us, one of the things we realized was that kids were getting different care depending on who or where they went. And so we decided as an institution that all children should receive the same care, regardless of which clinician they see, regardless of which location they go to, or regardless of any of their own personal traits, their income, their insurer, their height, their weight, their sex, their race. We think everybody should get the exact same care. So in order to facilitate this, we created something that we call a standard work group. And the standard work group is the standards incorporate all recommendations and all requirements as outlined by institutions such as the American Academy of Pediatrics, American Academy of Family Practice, Bright Futures, the Minnesota Department of Health, and the Wisconsin DHS. Said simply, standard work basically creates a complete package so that our care teams can use this very simply whenever they're delivering care to children. And this package contains everything that the children would need in order to live a full and productive life. In addition, we tried to make this as simple as possible so that all care teams are able to use the product regardless of how often or how infrequently they might serve children. Some of the care that we standardized includes, but it's not limited to, well child care. We clarified everything that is important that should make up a well child care. We then standardized and incorporated that, and we created it so that it's in a requirement. So now every kid who comes into our system for a well visit gets every single check mark done as required by any regulatory body or other important institution. Same thing for immunizations. We tried to make it as simple as possible for all of our kids to get immunizations whenever they need it, however they need it. So if they're a walk-in patient, if they're in urgent care, if they're with their primary care clinician, we want to remove all barriers and make it so that everybody's in alignment here. Developmental and emotional health. When we started this some years ago, we realized there was a massive disparity in terms of the social emotional health and the developmental outcomes for our patients of color. So we created standards for when screening should be done for all of our kids. And in addition to that, we trained all of our staff about the need to do this, the why we need to be doing this, and in addition to that, how to interpret and understand the results of the screening, and we created resources to use for when a concern is raised. We did the same for social determinants of health and social health. We do social determinants of health at all well visits. We taught all of our staff about this. And again, we created resources for our teams to use if a family has food or housing insecurity or some other negative social determinant of health. As I said earlier, all of our initiatives, as we're rolling them out, we all now try to analyze them before we roll them out. How will this affect diversity and inclusion? And this will allow our teams, by the time it's rolled out, this allows our teams to focus on the care that they are giving, and they can help reduce their own concern that they may be part of an inequitable situation because we've already thought about that on the front end. In addition to that, we've leveraged our electronic medical record. We happen to use Epic. There's a bunch out there. And we found that actually Epic is a wonderful tool that can be used to reduce inequities and improve health equity. For instance, Epic is able to predict all of the care that is recommended and or required for our patients. It can also automatically pen and sign these orders, and we can set it up in a way that helps walk our teams through the process so that nothing is missed. Doing this significantly reduces disparities. And we didn't show data, but I'll give you an example. Years ago, for our patients of color, only about 10 to 15% of the kids were getting true developmental screening. After we came out with our standard work, that number jumped from 10% up to 85%, and that was in 2 months. So it just showed it was an operational problem that we had, and by standardizing, we improved it. So for us, we tried to also make it simple on our care teams. All our LPN CMAs have to do is go into the room, open something that we call a smart set, and pend it. That's it. And then it walks the LPN CMA through the visit, and it also walks the clinician through the visit. This makes it easy for our teams to deliver excellent standardized care. In addition to that, we have been able to set up Epic in order to actually look at equity because, as we said, some patients do need extra services. So we want to give everybody an equitable outcome, not just equality. So we can, as an example, prompt teams to ask for the social determinants of health. And if there's a positive answer, that means that they might need extra services. So this has actually significantly increased our social work consults, our mental health consults, and our consults to other food and housing insecurity organizations across the state. One of the big hurdles that we run into in addition to this is time. So our care teams want to do all of this, but they simply can't do one more thing. And so increasingly, we're looking through our operations and trying to figure out what really needs to happen in the visit with the clinician or the nurse and what can be pulled out and done centrally. So increasingly, we're doing more things centrally to take that work off of the care teams so that they can deliver excellent care when the patient is present. This also allows us to be increasingly effective at reaching our patients, who aren't coming in. So I can't serve my patients if they don't come and see me, but our centralized outreach team can if we do reports of who has not come in the last X number of months or years. And then in addition to that, we do have quality improvement teams, and they follow metrics for all of our health measures, and we split out the data, as Andrea showed you, by sex, race, and insurer, and we also do identify gaps, and we follow reports of each of these gaps every single month. The QI team then will work with the various leaders and care team members to complete the so-called PDSA cycle, which is, as a reminder, plan, do, check, and adjust. And the goal is continual improvement. The last thing that we are trying to do is really align system incentives with patient incentives. One of our biggest hurdles is getting patients to come into primary care and getting them to come in for their well child care. We found that incentives have really helped our patients align their desires with our desires. There are two examples that come off the top of my head. The first one is we started giving out Target gift cards to all patients who come in to get their lead level checked. Our lead level rates improved dramatically. In addition to that, every summer we try to partner with a local enterprise to give out coupons. The last few years we've paired with Cub Foods to give out coupons for free fruits and vegetables. The parents love it, the kids love it, and it gets those kids in for their well child care. So by looking at our unjust system and unequal system, we've been able to make some operational improvements that have made significant impact. And now back to Andrea.
All right, just adding on to what Jason said about some of the operational things, I think a couple other things just briefly I wanted to add. One was that, when we created our standard care, we also created process measures associated with that didn't necessarily look at outcome, because I think the process is also important. If our teams are not implementing some of this standardized work, then we're never going to have the equitable outcomes that we want. And so we have to do both as we move forward. And so I think having process measures was really important. That was a huge undertaking that started well before the pandemic and the murder of George Floyd brought some of these issues to light for the general community. And those huge disparity gaps that we somewhat closed, that Jason was mentioning once we operationalized that universal standards, were 3-4 years ago. So that gave us the advantage of starting at a better place when we started to have more conversations and dig even deeper into the persistent disparities that exist even with our universal standards. So I really have the pleasure actually of ending our conversation today in talking about trust, collaboration, and education. And the importance of engaging all of the different stakeholders into this work. We talked at the beginning about, all of the people that are on this call, all of the people that, touch children's lives are stakeholders. And we cannot underestimate the importance when we're talking about equity work of engaging patients and partners in the conversation. Whether you're a minority yourself and leading this work, as Jason and I are, or somebody that is a patient or a parent of a child, we in healthcare, and if you're invested in this and this is your job and your profession and your life's work, may have a different perspective from somebody who is not immersed in the system. And so the only way we're going to elicit the information from those we care for is if we talk to them. And we ask honest and open questions and include them in some of the decision-making and goal setting that we have as we are working toward better outcomes for these groups of patients. And I think that in care for children in particular, it is very, very important to recognize that this is not just pediatrics. This is family medicine. This is med peds. This is our schools. This is, our urgent cares and our specialists that care for children as well when we're looking in the healthcare field, because we would be remiss if we didn't include them in the conversation as they're still delivering care to kids. I also think it's important, and this is unique to care for children, is that we have to talk both with our patients and with their parents or families or guardians or whoever is actually the adult in the child's world. Because again, you're going to get different perspectives. They have different issues that they're bringing to the table. One of the really cool things that we've been able to do here at Health Partners in Park Nicollet is leverage the Power Up Teen Health Council, which is really just a group of teenagers that have applied and been accepted into this program that really is about fostering leadership for teens in healthcare. And they served as a wonderful patient panel for us and really gave some great insights into our teen questionnaire, which is a questionnaire that we give to kids when they become adolescents that help us kind of hone in on some of the social determinants of health. It asks about everything from potential drug use to gender identity to exposure to pornography. And those teen members of that council really gave us good input this last year into how we could better improve and enhance the questions that we ask. And it was actually their suggestion that we add a question about ever feeling discriminated against and how, really how that impacts kids. Because if we don't ask these questions in a routine well child visit, it's very common that kids don't bring it up. But yet it's a major issue that's affecting their mental health, their physical health, and their lives. And so, in well child visits, we have to do a lot and we have to set priorities. As Jason said, we love to do all of these things, and we have to figure out where we do set those priorities for a finite visit type. So it's been really neat to partner with our patients and our teens in particular on talking through where they see the priorities, because it might be different than where we see the priorities. We also, as an organization, have been really privileged to partner with so many different community agencies and members. Some of you may be familiar with the Little Moments Count collaborative that exists, and Health Partners has been a very active member in that group. For any of you who have not gone to the littlemomentscount.org website, I would encourage you to look there. And that website is really, and that group is really focused on promotion of early brain development and helping parents of young children understand how important it is to, talk, play, read, and sing with their kids, how important it is to kind of get those developmental milestones achieved early on, and giving parents resources to be able to do that regardless of where you're coming from, the color of your skin, your economic status, anything like that. There's also some great racial justice resources on that littlemomentscount.org website that are wonderful for parents. But that's been a lovely collaborative that many of the healthcare organizations and community groups in Minnesota that are invested in the well-being of young children have been a part of. And I encourage everyone on this call to take part in those kinds of efforts. We have also been a part of, other collaboratives and other groups, and that's a huge piece of this puzzle that we can't underestimate. In closing, I think Jason and I just want to reiterate how thrilled we have been to speak to you today about some of these issues. And to recap, you have to identify with your teams that this is a problem And that is not an easy conversation to have. So hopefully we've given you a few tools, and Jason's slide at the beginning is, or the slide that he resourced at the beginning is awesome in terms of helping to have that conversation with people and understand why this is important. Looking at your own systems and the product that you produce in the lives of children and saying, where do our disparities exist? Looking at potential causes and then potential solutions, and coming full circle on that PDSA cycle will be then measuring where, once you've implemented some potential solutions, if those solutions are sustainable, achievable, if they are doing what we in our minds hope are happening. So just keep fighting the good fight. I think one of my favorite quotes is from abolitionist Frederick Douglass, who said that it is easier to raise strong children than it is to repair broken men. And, that's what this work is all about. We know that we can make dents in this disparity gap in healthcare, and it is really hard work, one step at a time. But if we work together as a community, we can really get there. So I think next slide, we can open it up to questions. If anybody has them, feel free to put them into the chat. Thanks, Denise, for your comment. We are, I've been able to partner with MDH through a lot of the COVID work and been really excited for some of those partnerships. It's partly about breaking down silos because we all, really want to improve the lives of the kids in the Twin Cities.
There's that question there about vaccine concerns.
Yeah. So Annie is asking, do you have any activities specific to addressing vaccine concerns? And do you expect vaccine disparities will show up for COVID vaccine once it's available for under 12? Well, I can answer the second question really easily, and that's yes, because we see that for all vaccines, unfortunately, and that is what we have seen in the adult data. I think Health Partners actually has taken a really lack of a better term, aggressive or assertive approach in minimizing the disparity gap for adults with COVID vaccine. And actually, we have some fantastic results in that we are not seeing disparity gaps in our organization for COVID vaccine access. But that has been really deliberate work that has happened with real direct outreach and some changes in normal processes to help folks that don't necessarily have access or have extra questions about how COVID vaccine affects their communities, and more resource, quite honestly, to those groups. So I think we're going to have to do the same things for kids under 12. So, long answer to the second part of your question, Annie, is yes, I do expect there to be gaps, and we can do something potentially about those gaps if we put the work in. Jason, do you want to start with the first question?
Yeah, I mean, I can also address a little bit more about the vaccine part. So what we did with COVID vaccination specifically is because as I said, we have our health equity cabinet, and in addition, we actually have a vaccine equity work group as well. And so what we did is we created a vaccine equity work group that looked at specific causes for why we might have disparity. And the first thing that we found was access. So we were very deliberate with how we rolled the COVID vaccine out to make sure that from a location and a geographic standpoint, all patients had access. And we also try to be very deliberate about hours as well, so having it on weekends and whatnot. I think we would do the same thing as we go to younger children. In addition to that, we did meet with the community leaders to find out what their concerns were. And then we took that feedback and then tried to create educational material. And the educational material we used, we taped doctors like myself and other clinicians of color, as well as support staff of color. And we had them just do very quick vignettes that we put on our website and I think also on YouTube to help educate patients about what people of color, clinicians of color, nursing staff of color think about this vaccination. In addition to that, we collaborated with a lot of institutions around the state. So all of the healthcare institutions, the Minnesota Department of Health, et cetera, and also ICSI, if you know of ICSI, which is winding down. But ICSI created a wonderful FAQ, and a lot of it was focused on questions that were specifically brought to us by our communities of color, such as how many people of color were involved in these trials, What are the specific side effects of potential of people of color? How does this affect us? Were people of color involved in the manufacturing of this vaccine? So it was really going back and finding out directly from our community partners, what are their concerns, taking those concerns, and then trying to come up with an equitable way of solving this. In addition, we did this, I know others did, we did, I'll come back, we did a carve out, and the carve out was we tried to create extra access for our disadvantaged populations as well, so that they would be more able to access the vaccine. So in the end, we just have to be intentional about it. People ask, what is ICSI? I apologize. ICSI is the Institute for Clinic Systems Improvements. It is a group that was a collaboration from several health institutions. Unfortunately, it is winding down, but we hope to replace it with a different collaborative enterprise. And on a side note, that's one thing I don't think we got into because we didn't know if we'd have time. This is going to take multiple people. So Health Partners Park Nicollet, we cannot do this alone, nor can Fairview or Alina or Children's or Sanford or any of the other systems out there. We all have to work together. And a lot of this, I think, really accelerated under COVID, and I'm hoping that this continues, because one of the pieces we need to do is reach our patients where they're at. And they might not be in our medical system. So how do we reach them where they're at? Are they at a school? Are they at a community center, et cetera? But there are operational hurdles to having, let's say, health partners go to a community center. It makes far more sense to have a coordinated approach amongst all of the health systems, because the real goal is that all of our patients improve. So our goal is to have more collaboration so that we can maybe do things like schools, community centers, mobile vans, and that's, I'd say, more to come. And if anybody's interested, please email us.
And I know there's some great work going out there already, like with the HCMC mobile van and working with DHS to kind of work on those kinds of things. One thing I wanted to add as we wrap up here, and I know we're pretty much out of time, is that one of the efforts that we've used to help have those immunization hesitancy conversations is training our clinicians on how to approach that conversation. You're not going to convince anybody that's vaccine hesitant to get a vaccine if you don't ask and you don't talk through it in a way that helps them understand why the science says that it's important, but also makes them comfortable with that. Again, it goes back to that trust issue, but that's a skill that you have to learn and you have to understand. Not necessarily something that comes intuitively or something that you're taught in medical school or nursing school. And so we have been very deliberate with our clinicians. This was even pre-pandemic and pre-COVID vaccine conversation about helping our teams have access to the education and do some trainings. We've done some maintenance of certification for clinicians so that they're also getting credit for licensure when they do these trainings, so that we can have better conversations with our patients that meet their needs, answer their questions, and get to the ultimate outcome of more equitable immunization administration. All right, I think we're pretty much out of time, and I think we got to the questions. We have loved being here with you guys today, so we appreciate your time and your commitment to this really important work.
Thank you so much, Dr. Maxwell and Dr. Singh. Thank you everyone who logged on for attending today. I believe that somebody put the link to the evaluation in the chat, so please complete that evaluation and let us know thoughts for future webinars, what else we can bring to you that would be a benefit to your work in this area. And like Andrea and Jason said, keep up the good fight. So thank you so much.